these are the questions which will give you whether this is OCD or depression. Do you get recurring like back and forth, unwanted thought? Does it stress you out? And does it make you think that these are the obsessive thoughts? Okay, because you ensure the confidentiality, he will talk about it. Do you think their thoughts are your, or do you think the thoughts are rational? Do you think they are excessive, unreasonable? Okay, so usually OCD people are distressed because they are actually find this thought irrational, coming over and over again, and they are thinking they're unreasonable because it seems something like, go and do it, go and do it. They feel like that and they are excessive. Okay, have you tried to resist these thoughts? And if you yes, what did you do it? Like one, like what they do is they do things in order, things in color, or they do something. So are you need to ask, next question is a ritual thing. So before you ask ritual, you need to actually what you do to relieve this thought. So they do it like they trying to actually wash hands, and they're so repetitive that could be tired of it. Okay, and they're tired, and but it failed it. Okay, what you do apart from this as a ritual. This guy with the king case gave a hand washing as a history. Yes, doctor. If you go into that ritual part, then yes, that. Or again, the lady who thinks that her boyfriend is cheating, she says that she does this count backward from 10 to 7, and the thought disappear. Okay, they will tell you the ritual. And again, the OCD people are perfectionists by nature. They consider that they like things in order, the color, or in the sequence, and they will be not very happy, but they love it. Like the door should be closed, knobs should be clean, so they will be off. And again, it does affect their life because their partner will be annoyed, or the people they're living around, they will be annoyed because they would be the one who would be spending entire day doing this thing. Okay, and they get late for the meeting, they're late for the studies, and they can't focus because they have to finish the ritual. Okay, now this myths cap is a question for your depression. We do need to ask, because all of these things happening, are you experiencing depression? Because if you do not ask this question, you have a fail side. So you better ask that. So what are the moderate depression question? I was teaching yesterday, day before yesterday, to someone that borderline personality as well as body dysmorphic disorder, you need to have at least assess the moderate depression. Mild depression will disappear, moderate depression would not. So what are those questions? Anhedonia, low mood, and sleep disturbances. They do have that in some cases. So you need to ask this: have you experiencing low mood recently because all of this going on? Because anything excessive like this, they will be depressed about that. They will not be happy. So you need to ask that. Have you been lost interest? Or you actually avoiding the social circle? That is called psychomotor retardation. So you have to assess this. And sleep is the best question. Even though if you get all of the questions, sleep is the best question to assess that person is having depression. Because they can be having some emotional factors, but sleep will tell that is person clinically depressed. So do you actually have a difficulty initiating sleep, which is anxiety? And again, do you have get middle of a night, or do you get middle of a night because of nightmare? So that you have to ask that. That's the three things you covered here. So at least you're covering the differential. Guys, remember that psychiatry is all about differential. And again, in psychiatry, everything you manage the patient with the examiner, not the patient. Unless and until this one you have to tell to the patient, you will be talking about the patient. But majority of the cases like borderline personality, depression, mania, all management will go to the examiner. Examiner will be asking you differential. And again, I usually start with this question, and again, I do ask about something to do with organic problem. If you're not giving organic differentials in the exam, I'm sorry. If you give only diagnosis and you walk away, you will fail. The aims is all about differential. And please, the relevant differential. Remy actually went there and giving linear something nonsense to. She was telling me she didn't reach to the diagnosis, but she gave differential. But she didn't give me that what was the relevant differentials. Okay, you need to have a relevant differential. If your the differential sounds like sexually transmitted something, and that not to do with anything with the right now at the moment common cause, they might not be happy. So relevant differential, 5 differentials are important, whether it's given there in the question or not. Okay, so you need to ask about suicidability. In all the cases, a mental health issue. health, suicidability. They in this case we don't ask, are you feeling like killing someone or are you feeling like hurting yourself? That's the wrong question. Suicidability, how do you ask? In this question, especially the mood disorders, this is the mood disorder, okay? Anxiety, stress, mood disorder. So you will be asking this person, are you finding life worth living? Please have adequate questions. Somebody, I was actually doing MSc, and that lady asked me, do you think you can harm others? In a depression question, do you can harm others? No. Schizophrenia is the only patient who will be thinking, or psychosis only the patient will be thinking harming others. The someone who attempted suicide would not be considering actually homicide someone. So you don't ask that, do you think that you can take a knife and cut someone? No. Have a adequate question, please. Do you find life worth living? It's fine. If you don't, if you run out of the question, this is the best question to assess the suicidability. Okay. And how's your do you know, are you suffering from condition? OCD people, the majority of time they know they are having it. They have insight. Same as the depression has insight, OCD has the insight. They personality disorder might not have insight, but these people have insight. They know that it's a real problem and they need a help. That's why they're there. Okay, and this one would be either brought by someone, but you need to ask insight about what? Insight about the three inside questions are there, and people are doing because they don't do proper inside question, they fail. What are those three inside questions? Inside about condition, inside about treatment, and the judgment question. So I will be asking this guy, do you know, do you have a problem? And he will say, yes, doctor, I think I need a help. That means inside about condition. Do you know there is a medical help there? Yes, doctor, I know about that. Okay, I know about it. So there is an inside about treatment. John, could you tell me a bit more about if there is a fire in this room, what you will do? I'll leave, doctor. So that is inside about judgment. So in judgment is actually a question part of the inside. It's not a separate question. That's why we call aseptic J. So you need to be also be assessing that suicidability and that. Now heads, whom you're living with. In this one he was living in a hostel, and home situation, yeah, parents are very caring and looking after him, but they live far. And smoking alcohol and recreational drug always needs to be assessed. Some of these problems actually start with alcohol intake, and some of these problems will start with acute psychosis conditions. Will start with any recreational drug. And I've been telling all of my students, please always ask thyroid in the psychiatry. If not, you need to ask that, have you seen noticing the changes recent with the temperature? You feeling more cold and warm? Have you one of your differential? Any recent accident happen, and then you have a change of that, like a bitemporal epilepsy, other things happen when you have a recent accidents, and then again dementia, the memory loss also happen. So whenever we do MSc, we have a part of a cognition in that is to find out higher brain function. Psychiatry is not away from the brain, so basically we will be asking those questions as well. So at least you have 2 3 differential drugs, obesity, thyroid, and accident. Keep that one as a standard. Please ask those questions, please. Family history of mental health, and past medical history of any medical treatment being done. Now, AMC has done recently, not this case, another case of OCD, where you had a lady was thinking of boyfriend cheating, and that case actually it came as an obsessive compulsive personality last year. Okay, not 2018, 2017 in March. It was obsessive compulsive personality problem, not OCD. And people who have actually not figured out it's obsessive compulsive personality, they fail this station. So what's the difference between obsessive compulsive personality, obsessive compulsive personality, obsessive compulsive disorder? There is a one difference. Obsessive compulsive personality, they are narcissists. They want everybody to follow them. Obsessive compulsive disorder, they don't want everybody to follow. They are the one who is doing the rituals and they're tired of it. Obsessive compulsive personality, again, they don't have insight about the situation. And again, at the same time, OCD has insight. They know they are having a problem, so they will be sitting here and talking to you. Obsessive compulsive personality, you know what, doctor, I don't have any issue. People should follow the discipline. So they would be like, and they make other people follow the rituals as well. Okay, so that is a major difference, and you need to assess in the question. Do you think the people get annoyed with your habits? Basically, that's the question. And do you get angry? That's the one question. Do you get angry if somebody not following it? They obsessive compulsive personality. It's a compulsive personality. They get angry if no one is following it. Okay. Do you guys actually listening, or do you all are sleeping with my speech? because that's what happens as well. When a long talk is happening, people run out of the sugar, and once they run out of the sugar, they all fall asleep. Everyone falls sleeping while I'm giving a speech. I'm a very bad teacher. Listening, okay. Everyone, just one person listening. Wide awake. Okay. You know what? Don't give. I don't know. I heard from someone with this one, what you call thyroid examination. The lady was making absorpthalmos, so she was popping out the eye, and people were looking. And the guy was actually went in, and he was like, "Why are you popping out eye towards me?" Rather doing examination. Same thing I'm not expecting from you guys. Like wide and awake, you popping your eye, giving me absorpthalmos while you're listening to me. And I was like, role play has to do something to give you exhaust elements as a finding. When you do physical examination with student, you come across with funny things. I was doing an MRC. They told me that, doctor, my role play was popping out like this. What does it mean? I was like, that means she was giving you observed thermosis as a finding. And I was like, okay. They give you all sorts of, the candidates give you all sorts of shit to you. I had a fun time in teaching. I will actually miss this part. When I start working, I will be missing this part. Do we need to ask? Yes, Sadi. If you're my candidate, you do need to ask that question. Insight about the condition, insight about the treatment, and the judgment. They are part of it. The people are telling me MSc, when they describe me MSc, they tell me only about the condition. Oh no, there is no insight. I was like, how come? Did you know that person? Actually, did you ask completely inside question? Then they were like, okay, doctor, what is an inside question? I was like, it's like inside about the condition, inside about the treatment, and inside about like judgment question. If you're not able to assess all three of them, you're not completed with the insight. Okay. Now, where you can get insight about all three of them? In person who's a suicidable and the depression. Depressed person will tell you, yes, doctor, I need a treatment. Yes, doctor, I'm having a problem. And they will be crying and they will be saying that to you. Okay. So they have insight about the condition, they have insight about the treatment. And when then you will ask about the judgment question, if there is a fire in this room, what you will do? They will say, doctor, oh, doctor, I might prefer to stay there. So it doesn't mean that actually the judgment is impaired, but yeah, they will give you an answer, or they will say, no, doctor, I want to live. Okay, so they will give you. So there are three questions there. Okay, so we have to assess all three of them, especially the question of a borderline personality, where you have to ask these three questions. One girl actually said, I will admit you in borderline person. I was like, no, you won't admit me. Did you assess my insight completely? She's like, you need a treatment? She asked me like that, do you need a treatment? I was like, yeah, I don't need a treatment. I had a hand cut. Let me go. So she said, you don't have insight. I was like, what? You asked me I need a treatment. I said, yes, I need a treatment for my cut. That doesn't mean that, how did you assess my insight? I need a treatment for the cut. She's like, you don't have insight for your condition. Personality disorder is a bit tricky. They will say you this, but she didn't ask me whether do I know anything problem with me with my personality. She didn't ask me appropriate question. Appropriate questions are very important for the MSc. You don't ask that, do you need a treatment? Maybe I don't need a treatment. The patient will say that, yeah, I don't need a treatment, let me go home. Because that is a discharge case, that they want a discharge. Of course, they will say, no, I don't need a treatment. And she said, no, you're impaired inside. You go. I'll admit you. Mental Health Act. She said everything to me. I was like, okay. No. So properly assess this. So what you ask, do you know that you have any problem, and do you need a treatment for that? Any problem, like you have any mental health condition? Okay, proper question of insight. I hope you don't guys make a mistake. Okay. So yeah, what are the DDs? Obsessive compulsive disorder, anxiety disorder, psychotic disorder could be any infection, hypothyroidism, or social issue, could be financial bullying, or university problem. Okay. Explaining obsessive compulsive disorder is an anxiety disorder where you're feeling anxious all the time. Most you can push aside, move on, but you can have a recurring thought. By the way, there is a one question which makes it okay OCD and obsessive compulsive personality also differentiate is that your thought, or is that your thought, or you get it this recurring thoughts. Okay, your own thought, is that your own thoughts? Basically, that's the question. Is that if they say their own thoughts are there like that, they have a problem with the thoughts, that means that's an obsessive compulsive personality as well. So you need to ask. Or recurring in one unwanted thoughts, recurring unwanted irrational thoughts. They find they find it unwanted. They're there all the time. They close their eyes, they're thinking about it, they're talking to someone, they're thinking about it. That's OCD. Okay, it really makes sense. Like, I don't have OCD. I do. No, I don't have OCD, but I asked myself, do I have an OCD? No, I don't. So irrational thoughts. Okay. So what is yes, this is important bit. I'm actually telling all of my students who wants to pass. Please, AMC is looking for specific CBT. He don't say that when you're talking about your treatment portion, go have a CBT. Okay. So when you're talking about the treatment plan, you do need to talk about what you're going to do in terms of a treatment plan, what CBT will be giving. If you're not using specific words of CBT, then then it might not be a pass, or maybe borderline pass if AMC examiner is like having mercy on you. Okay, so you will do exposure response prevention therapy. So they will be exposing him the word king quite a, or we might show the king as a picture, or what they will actually talk about the words itself. So they will do that, and what will happen? They confront the fear and to make it stop the ritual. So they have this plateau. When they develop the anxiety, they do obsessive compulsive thoughts, and what they do, they do the ritual. They come back to the mountain. So you draw the mountains for him. This is what happening. You one triangle, another triangle, and up and down, up and down. So what we will do with exposure behavior response prevention therapy, we will expose you the thoughts over and over again so that it become plateau, it becomes straight. You don't have this compulsive thought to release. So over a period of time, it will be actually solved. Okay, so exposure, confrontation. And we do other techniques as well. We do and management techniques, relaxation, slow breathing technique, mindful meditation that helps you out. How many settings you needed for to with the cognitive behavioral therapy session? You at least minimum need 12 weeks to have a proper treatment, or 12 setting per weekly. Provided if it doesn't happen, so maintenance we will be giving again another 12 week of trials of SSRI. And SSRI, they usually have this comment, doctor, don't you think that's a depression medicine? Yes, it is, but it is actually anxiolytic too. It's the same medication work for both, but for depression, we actually expect the treatment to be beneficial in the 6 weeks time, 6 to 8. But for the OCD or other problem, anxiety problem, we give it longer time. Then you will have effect, because usually these people might be having already treatment going on, and they'll come to and say you, oh doctor, I'm having already treatment going on and I don't find any effect. You will find effect only after 12 weeks, of course, even with the SSRI. So you need to do that. And you keep up with the follow up. You will give in the links. And again, these are the difference between obsession and compulsion. And again, OCD does run in the family. That's why we asked that question. OCD, does it actually, is it runs in it? Yes, it is. It runs in the family. So this is your cycle. Okay, clear? Oh yeah, this question. I was discussing this question yesterday. Someone, yeah. Everyone clear with the OCD? And now, did you find out? Do you have OCD? You should ask a question. Yes, I do. I have IBS, OCD after reading this. Yeah, actually, when I used to do psychiatry, I used to give a call to my boyfriend. I was like, "Hey, I think I have OCD." Then, mate, I think I have an eating disorder. Now I'm having a depression going on. Then I will be, now I think I have an IBS before exam, and after the exam I have a PTSD. I don't want to talk about AMC. So yeah, check yourself if you're actually developing. Those questions are very important. Okay, next is this one. This question is a failing question. Regardless, I tell you everything. I'm not giving you. I'm giving you breaking bad news here. So what is happening in IBS? Actually, it is an IBS. Why I give you diagnosis? Okay. Read this and tell me what is the diagnosis. No, we should not do this. This is just not. No spoon feeding. Okay, tell me what is happening here. Exactly the same in my question in my exam. Exactly the same, just with day before yesterday for same exam. Same question. same stem. It was maybe in 2012. Karen has the same stem. So tell me more. What is this exactly? What we need to rule out? What is this? What is happening? What are the differentials? Okay, we start with that. We have a one story differential. So what are the differential I'm expecting in this one? Yeah. Let's see what we say. Yeah, IBS. What else? Long-standing history of constipation. Okay. Yes. What else? Okay. Except diverticulitis and IBS. What else are you thinking? Okay, 1 second. It says that they have done blood test, gastroscopy was normal, stool examination normal, thyroid normal, colonoscopy normal. Celiac disease, yes. What else? She could be having functional constipation as well, right? Thyroid normal. It's given thyroid normal. Don't ask the things which are not there. Something else you need to rule out apart from this, which I ruled out in my case as well. Yes, colorectal cancer, very good. What else? Colonoscopy done, normal. Cancer and IBD ruled out. Psychogenic is IBS, dear Augustine. Fibroid, yep. Good, we're thinking. We're thinking differentials now. I've been telling you the things which they give you means you don't want to explore them. The things is not given, you want to explore them. Okay, if we will just talk about IBS throughout, because there is a history taking in this case, not be enough. She's 52 years old. What about her problems with her periods? Do we think need to think about that? I like the fibroid as coming as differentials, gynae causes. I'm talking about. I'm redirecting because you need to take further history in this one. Look at blood test done normal, gastroscopy done normal. So we know it's not because of NSAIDs. We know that there is no stool problem. Thyroid normal, colonoscopy. I know this is IBS, but people are still failing it because they are not doing adequate differential in this one. So this is why I'm asking, what are the differences? Because this case was completely about differential. And yes, they will fail you for differential if you say only IBs. Trust me, they will fail you for that. If you just say IBs. Everybody knows this. Everyone knows. What can give you tummy pain? Do you think surgery has to do something with here, guys? Everyone, any abdominal surgery? If it all surgery, with surgery, I will be concerned. You don't think trauma and surgery, right? None of you will think of trauma and surgery. None of you. Think of more about differential, please. IBS came this year lot number of time in a different age group. What else can happen? What infection can give you a problem? Yes, addition. Small bowel obstruction can happen. Large bowel obstruction can happen. Where that gone? That is the only thing has not ruled out in this case. Whether it's a gynecological surgery or medical treatment or any medical surgery, has to rule it out. And I will give you the presentation what my role play was doing in my exam. Evidently is coming. I have to teach to you. Okay. From 3rd April to now, and this was my last case in my exam. And trust me, I was so pissed off with everything with the AMC system. I was like, I couldn't be bothered asking too many questions. It's a key issue if we do not ask malignancy. If you ignore malignancy despite the matter of fact of all what's going on, psychogenic, it's a critical error. Okay. And none of you I know will discuss about menstruation problem. None of you will think about surgery. AMC examiners are very tricky. And this exam is actually tricky. They're giving you investigation, they're telling you this has been ruled out. Don't go and explore something which is ruled out in the question. You need to ask further history. Although it sounds IBS, it's overlap medicine and psychiatric case. So you have to find out medicine, surgical causes, and the psychiatry. Please don't do that. You will lose the station, and people are losing station of because they go and explore. Okay, we have done then gastroscopy is done. Sometimes they go lost. Okay, why there's so many tests has been done and they were normal? It could be somatoform disorder if it's a psychiatric because they have a preoccupied thought problem. You need to don't say psychogenic somatoform disorder, somatization. This can be not necessarily just an IBS. Okay, I didn't get that any one of you saying this. Yeah, hypochondriasis. Okay, she have an ideation that something wrong with the leukosa. None of you. Psychiatry has to have a relevant. It's don't take it as an IBS only, which is very likely people did and they fail. Ensure the confidentiality. Celiac, Crohn's disease, ulcerative colitis, lactose intolerance. No one of you that she's taking milk and she's getting bloated tummy. Okay. Thyroid problem could be there. Colorectal cancer would be there. Thyroid problem has been ruled out, so don't waste time there. So I remember I walked in the room, same presentation there in the real in this exam as well, the last one which we had, and the lady was like, as soon as I sat down, she was like, "Oh, doctor," I'm like, "Yeah, doctor, yeah, yeah." I'm having this constipation and diarrhea. I'm sick and tired and going to doctors all over the time. It's been happening past 3 years. So she gave me proper history inside the room. I didn't have to ask. We start throwing up because they do that. And I started having this thing, blotty tummy, and then I get hard stool, and then sometimes I get mucousy stool. Like okay, and explosive stools. And again, I went to doctor over and over again. They don't do anything. I went through all of this investigation. They turned out to be everyone tell me it's normal. I'm like okay. So first thing you need to be talking about I did is exactly ensure confidentiality. Then she became calm. Okay, because I had this private questions was in my mind, menopause and all that stuff as well. Plus, this is overlap question, medicine and psychiatry. So I was like, okay, can you describe me about the diarrhea? Can you describe the frequency of stool? Very important. You have to ask frequent diarrhea episodes. So I asked like, how you get the stools? Like hard, then mucousy, watery. What happens? You should be knowing that functional inconstipation they can they don't have just only a hard stool. They could have sometime mucousy stool coming out. Okay, because they get stored and collected, and they could have explosive diarrhea as well. And that's one of the features. Fecal incontinence can have. So you need to ask that feature. How frequently going for toilet? Then she said 3 to 4 times, which is giving you again functional constipation. I was like, okay, she does have a constipation. And have you seen notice like sometimes you get explosive stools if it's not frequent, what kind of color it is? And again, ribbon likes stool, ribbon. Okay, like thin. That is the gist of IPs. So she did not